Thanks, John. So, as mentioned, my name's Jeram. I'm an intensive care fellow in John Hunter Hospital in Newcastle, which is a tertiary hospital with about 800 beds, about an hour and a half, 2 hours north of Sydney. And what we wanted to look at in the study was the degree of rebound hyperthermia that we see in patients after they've had a out-of-hospital cardiac arrest. So first up, I've got no affiliations, and unfortunately no one's given me any free lunches lately beyond the nice lunches out here, and we have no disclaimers to give. So a bit of background, whether you're going for 32 to 34 degrees or 34 to 36 degrees, it'd be the gold standard around the world to provide targeted temperature management for the first 24 hours after a out-of-hospital cardiac arrest. We know, though, that extending that out to 48 hours in the TTM-48 trial didn't provide any benefit. But lots of studies now have shown that rebound hypothermia, which is a temperature over 38 degrees, is very common after that initial temperature management period. There's not a great amount of guidance in the literature on how aggressively to treat this and how deeply we need to sedate patients to prevent the temperature, or whether we tolerate a little bit of it. And the evidence around the effect of it is varying depending on each of the trials you look at. But we know that in all the other kind of neurological injury domains, from stroke or traumatic brain injuries, that having a high temperature is associated with a bad outcome. So quick look at some of the studies that have come out in the past, and we see here that it ranges between about 40 to 64% of patients who are given targeted temperature management end up having rebound hypothermia. And each of these studies has, like I said before, a varying association with either increase in mortality or an increase in neurological morbidity, or in some cases no association. And anecdotally, and I guess the reason why this study came about was my experience is that in our hospital it seemed very much like this. We didn't at the time have any fancy technology or cooling blankets, and so we were providing cooling with very much what seemed like Han Solo frozen in kryptonite and carbonite, and so we were putting ice on the patients in bags and some wet cold towels. And from my experience as, I guess, a little bit of a perfectionist, it didn't seem entirely that effective, and it seemed at times a bit cruel, and it seemed like we're having to sedate our patients a little bit more. And as all intensivists experience, we had a little bit of technology envy, and it seemed like everyone else had all these fancy devices, and St. Elsewhere had these very happy, pleasant patients. I've looked at this photo maybe 1,000 times, and I swear he's not intubated, because I've never seen a smiling, happy, intubated patient. But, you know, apparently these wonderful different devices that we didn't have made patients very happy while they're being cooled, which was very different to our experience. And certainly it felt to me that we weren't achieving good rates of temperature control after that first 24-hour period. And so I looked a bit more into the TTM trial to see what kind of guidance it gives, and it's a bit ambiguous. It just says control their temperature while they're unconscious, aiming for below 37.5, and how you do it is really up to the discretion of the different ICUs. I looked a little bit into their appendix to see what kind of results they got, and thankfully their appendix gives us a little bit more information. It shows kind of day 2 post-arrest, so this is the first day after they stopped cooling, day 3 and day 4, and you can see that their highest recorded temperatures are 37.2, 37.8 and 37.9, and thankfully they give us the standard deviations around that. And so from this data we're able to, I guess, provide at least a target to kind of quantify ourselves and test ourselves against to see how we were performing against the TTM trial. And so our objective was to perform a trial looking retrospectively at all of our patients that we provided TTM to who had met the criteria for TTM, and to compare it to the TTM trial based on that data from the appendix. So how we did it was a retrospective observational study over a 30-month period, and we used the same inclusion-exclusion criteria as the original TTM trial. So we're looking at adult patients who've had an out-of-hospital cardiac arrest who've come into hospital and remained comatose. So our primary outcome was the incidence of rebound hypothermia compared to that seen in the TTM trial, and we also really wanted to look into the background a little bit more and see some secondary outcomes in terms of our mortality, our length of stay for these patients, how long they were spending over 38 degrees if they were having rebound hypothermia, and how high the temperatures were getting, because anecdotally some of them seem to be having quite high temperatures, and that's kind of, I guess, what started this whole research off. And we also wanted to look as well as how long they were needing to stay ventilated as a little bit of surrogate to see how much sedation we're having to give them to achieve our temperatures. So overall, we screened 3,000 and a bit patients, found 181 out-of-hospital cardiac arrests from that 30-month period, and 72 of the patients actually met the criteria for the TTM trial. The main reasons they're excluded were there was a couple in-hospital arrests, some respiratory causes, and some traumatic arrests. So we ended up with 72 patients in our study. And looking at their baseline characteristics, as you'd expect, the people who are having out-of-hospital cardiac arrests are around in their 60s. They're predominantly male, and they have a smattering of past medical history with some hypertension and some previous ischemic heart disease. And you can see there the comparison to the original TTM trials 36-degree group. Most arrests happen at home, and thankfully most of these people have someone that loves them or at least wants to resuscitate them, because most of them have bystander CPR. And as you'd expect, most arrests, 75% of them are VF arrests. Most of the patients, when they first arrive in the hospital, have a temperature of around 35.8, and they're usually a little bit acidotic with an average pH of 7.1, and their lactate averages around 7.9, and most of them have taken about 25 to 30 minutes to get ROSC. So our results, we found that overall 42% of our patients are actually having rebound hypothermia after we stopped actively cooling them for the first 24 hours. 18% of those patients were actually having temperatures of over 38 degrees for more than 4 hours at a time. And when we looked into how high they were, though, it was actually pretty consistent with the TTM trial. So you can see here that we're having highest recorded average temperatures of 37.6 on day 2, 37.7 on day 3, and 37.6 on day 4, which is not statistically different from what's seen in the TTM trial. But I guess what we wanted to know a little bit more than that was if our group overall was having overall the same kind of temperature results as the TTM trial, were there actually any months or time periods? We didn't quite go into the same detail as John did in terms of looking at actual intensivist weeks, but we wanted to see, was there any time periods where perhaps we had some outliers that we could improve on? And so what we did was we used some process control charts. And if you haven't seen these before, process control charts are a way which they use in industry to look over time. Usually it's used in industry for production, but to see if there's any outliers. And so the red line in the middle there is the mean, and these are derived from the TTM trial's appendix. And so we're comparing against the TTM trial. So the red line here is the average temperature, average highest daily temperature. The next line above it, the grey line there, is 2 standard deviations above that, and the black line above that is 3 standard deviations above. And so that's made from the TTM trial's supplementary appendix. And so the black line being 3 standard deviations above will show you that 99.7% of all patients' results should lie between those 3 black lines. And so that would mean that any patients or months that are crossing that black line would be outside of the range which were consistent in the TTM trial. And we looked across days 2, 3, and 4 after we stopped cooling them and found that all of our patients actually fell within the same range of temperature control as seen in the TTM trial. We did have a couple that approached or got to the limits, but none of the patients got outside the same range that the TTM trial had. And that actually, I guess, surprised me, because anecdotally, as a clinician looking at individual patients, I get quite upset when I see a patient with a higher temperature, but I guess it also reminded me that this does happen and that you can't prevent every temperature. And looking at the bigger studies on this, we see that this is consistent with what's happening in them. We also looked into a little bit, and we found that on average our patients, if they were febrile, were only febrile for about 2.9 hours over 38 degrees, and that only about 4% of their time while they were still unconscious after that first 24 hours was spent over 38 degrees. We used a little bit more surface cooling than the TTM trial. We do have intravascular cooling devices available, but we only used them in 14% of the patients. And we did find that our
stays in ICU are mechanical ventilation, and our stay in hospital was actually a little bit shorter than the TTM trial. We have a very small patient subset, and so I wouldn't read too much into that. And it may just be that we ended up palliating a few more people when you look into our numbers than in the trial, and that may just be a product of it not being within a trial. But what we were able to do, though, was actually show that even though this is consistent with the TTM trial, I still don't think we should be having patients who are having high fevers or being over 38 degrees after we stop cooling them. And so we were able to show that we are still having fevers, and we were able to use this to get funding to get some new Arctic sun or cooling blankets in. And what we're going to do from here is trying to see over the next 30 months as to whether or not the implementation of what perhaps might be a more comfortable way to cool them may lead to a decrease in our ventilation times and our sedation times, and whether we actually end up with better temperature control, and whether we can actually show in the next 30 months whether our temperatures can come down. But I'm sure that this will continue to evolve, just like Mr. Freeze has evolved in the Batman movies over the last couple decades. I'm sure this, and our targets for temperature control will continue to evolve, particularly while we await the TTM2 trial. So that was our study. Thanks.